Hello students, a very good evening and happy Independence Day to all. Hypoglycemic agents continuation part 2. In part 1, I discussed about the general mechanism on homeostasis of blood glucose level to be maintained. Okay, so now discuss about the diabetes mellitus type 1 and type 2 and the hypoglycemic agents, mechanisms and areas. The mechanisms and important areas of hypoglycemic agents, the types of diabetic mellitus. So what are the types of diabetic mellitus? How many types of diabetic mellitus are there? There are two types of diabetic mellitus. One is the first one is type 1 diabetic mellitus and the other one is type 2 diabetic mellitus. The diabetic mellitus type 1, which is an autoimmune disorder. Okay, I think you know aware of it. And let me revise a brief introduction about the type 1 and type 2 diabetic mellitus. Okay, the type 1 diabetic mellitus is an autoimmune disorder. So it is caused due to the genetic susceptibility and environmental exposure. So in type 1 diabetes, in the type 1 diabetes, the immune cells, okay, our own immune cells, the immune antibodies or our own immune cells by mistakenly attack our own beta cells. Okay, immune cells attack own beta cells. It destroy the beta cells. It destroy the beta cells of pancreas which are producing the insulins. So when the beta cells are destroyed, it leads to secretion of insulin. When the beta cells are destroyed, it leads to secretion of insulin. Does insulin secreted when the beta cells are destroyed? No, there is no possibility. Insulin is only secreted from the beta cells of pancreas, right? So, but in the diabetes mellitus type 1, our own immune cells, okay, it is an autoimmune disorder. That means our own immune cells by mistakenly attack the beta cells. It destroys the beta cells of pancreas. So when it destroys the beta cells of pancreas, so the cells which are producing the insulin is decreases. So when the beta cells are destroyed, there is no insulin production. Then there is no production of insulin. Okay, due to destruction of insulin, there is less production of insulin or absence of insulin in the patient. That is type 1 diabetes. No oral drug for the treatment of type 1 diabetes. Okay, the one and only option, the treatment is, what is the treatment? What is that one and only option treatment? That is insulin injection. The insulin is only available in one form. It is available in the parenteral form and given in the subcutaneous route. Yes. The next one is the type 2 diabetes, the type 2 diabetic mellitus. In the type 2 diabetic mellitus, so the insulin is there. Okay, the insulin will be, there is no problem with the secretion of insulin. The insulin is there, but the patient develops resistance. Okay, the person develops insulin resistance. What is meant by insulin resistance? Insulin resistance means the insulin is there, but there is no action. There is no cell, the target cells. Okay, there are no target cells or tissues respond to that insulin. So there is no action. The insulin is there. There is no problem with the quantity of insulin. Okay, no problem with the secretion of insulin. Insulin is there, but there is a problem with the action, the quality. Okay, we can differentiate as quantity and quality. In the diabetic one mellitus, okay, the diabetic type 1, so there is no insulin secretion because the beta cells are destroyed by the T immune cells. The T type immune cells destroying the beta cells. There is no secretion of insulin from the beta cells, right? No secretion of insulin from the beta cell in the type 1 diabetic mellitus. That is quantity. The insulin secretion is slow or absence. So we can say it is quantity. And here in type 2 diabetic mellitus, in the type 2 diabetic mellitus, the insulin is there, but the patient develops insulin resistance. Okay, the patient develops insulin resistance. So due to that, the insulin will not show any action. Okay, the insulin will not show the action of reduces the blood glucose level. So we have to, for the type 2 diabetic mellitus, the drugs are available. They are oral drugs. So the oral drugs are available in the market. So those we are discussing now. We discussed now. So those are the drugs are available in the market. Okay. So those we'll discuss now. So what are they? They are hypoglycemic agents. Oral hypoglycemic agents. For type 2 diabetes, it will be used. The oral hypoglycemic agents are useful for the type 2 diabetes. Only for type 2 diabetes. Okay. Because here the insulin is there, but there is no, what happened? Insulin is there, but there is no action. Insulin is there, but there is no action. Okay, that means here the defect in the quality. Defect in the quality. The quantity is there. Quantity is there, right? Insulin is secreted from the beta cell as normal. But what happened? It develops insulin resistance. Insulin resistance, that is, the body or target cells will not respond to that insulin. Okay, so we'll give the oral hypoglycemic drugs to respond the body cells to the insulin. Respond the body cells to the insulin. The drugs will make the response of body cells to the insulin. Okay, when it releases from the beta cell. Yes, let's discuss about the hypoglycemic agents. The hypoglycemic agents are classified into the different classes of drugs. Okay, they are subdivided into different classes of drugs. The first one we'll discuss about the potassium ATP channel blockers. The potassium ATP channel blockers. I think you know ATP-sensitive potassium channel. Okay, in my last video when I discussed about general mechanism of blood glucose levels in the beta cells, the potassium ATP channel is present. Okay, that potassium ATP channel, is present in the beta cells. So these drugs, the potassium channel blockers or inhibitors, are going to block that potassium channel. Okay, so where it is located? In the beta cell. Okay, so these are the drugs. So there are again under the potassium channel blockers, there are two types. Okay, two types of drugs, two classes of drugs. One is sulfonylurea and the other one is meglitinides. Sulfonylurea and meglitinides. So both are comes under potassium ATP channel blockers. So what are the drugs comes under sulfonylurea? There is tolbutamide, glibenclamide, glipizide, gliclazide, glimepiride. Okay, glimepiride, tolbutamide, glibenclamide, glipizide and gliclazide, glimepiride. Okay, these are the drugs which comes under sulfonylurea potassium ATP channel blockers, KATP channel blockers. Okay, yes, let's discuss about the mechanism of all these drugs. So any of the sulfonyl drug which is binds with the sulfonylurea 1 receptors, SUR1 receptor. There are two types of receptors. Of sulfonylurea. Okay, one is SUR1 and the other one is SUR2. SUR1. So where is the location? The location of SUR1 is on the potassium channel, on the potassium ATP channel of beta cell. Okay, the location of SUR, sulfonylurea 1 receptor, is located on the ATP channel, on the surface of ATP channel of beta cell. Okay, and there is and I also said there is other receptor of sulfonylurea, that is SUR2. Right, that SUR2 is not required here because the SUR2 location is present in the cardiac and skeletal muscles. And SUR2, again the SUR2 has divided into SUR2A, SUR2B, two types receptors, the sub-receptors, SUR2A, SUR2B. SUR2A is present in cardiac and skeletal muscles and SUR2B is present in the vascular cells. It is present in the vascular smooth muscle cells. Okay. When you are studying about the mechanism of action of any drug, not only hypoglycemic agents, you must know the type of receptors. The type of receptors to which the drug is binding. The drug is binding. You have to know when you are studying about any drug of mechanism. So you have to know the drug which is bind with the which type of receptor and where it is located and what is the function of its receptor. So when you get to know all of this, so it is very easy to learn the mechanism of action. And so when you learn the mechanism of action, obviously you will get to know from the mechanism of action you will know. So when you understand the mechanism, definitely you will get, oh, these are the adverse effects will come because the physiology has been changed. So it will be, so this will be affected. You will get to know all these things. So when you learn, first you have to learn the receptor. The drug is binds with the which type of receptor and the location of receptor. Then function of receptors. These are the very important. These three are very important to learn the mechanism of action of any drug. Okay. So and the SUR1 receptors. So here why I am explaining this is why I am lagging here. Why I am expanding here, because so every people will, so anyone, even while I am studying in my graduation, I will confused to remember all those mechanisms of drugs. So but now I get clarity when I became a faculty, when I am teaching to my students. Now I got a clarity, that is, so you have to learn first receptors. Okay. You have to learn first receptors and their location and their functions. When you learn in this way, so it is very easy. It is very easy to write in your university examination and also in the competitive examinations, whether in the state or central examination. So let's see. For example, SUR1. Not example, really. Okay. In the previous drug inspector examination, from the hypoglycemic agent and specifically from the potassium ATP channel blocker, they asked a question. They asked one question. Okay. They asked a question in the 2023 conducted DI examination. What they asked in the DI 2023 examination, what is the question? They asked about glipenclamide. The glipenclamide is binds with the which of the following receptors? The glipenclamide of potassium ATP channel blockers is bind with the which of the following receptors? This is the question came from the 2023 DI exam. Okay. And what are the options? The options they gave is SUR1, SUR2 and some other two receptors, that is DPP4 and PPAR. Okay. Those are the other receptors of hypoglycemic agents. Okay, this is a question. These are the four options are given. So you will know. You have clarity. DP4 you will eliminate DPP4 and PPAR. You will eliminate easily. You eliminate both the options easily. But the confusion comes in between SUR1 and SUR2. Both are sulfonylurea. You know the drug, the potassium ATP channel will bind with the sulfonylurea receptor. But you have to know specifically whether it is binding with the SUR1 or SUR2. Okay. So the option is, what is the correct answer? Where is the location? Where is the SUR1 receptor is located? It is located on the beta cell. So what we require here to reduce the blood glucose levels. So beta cell. If you remember the receptor location in the beta cell, so definitely it is the answer SUR1. So you will be click for you, that is SUR1 will be the answer, because SUR2 receptor location is where it is located. It is located in the cardiac and skeletal muscle. The cardiac and skeletal muscle is not related here. So mainly to reduce the glucose levels, it will be interfere with the beta cell. So when you know the receptor location which is present in the beta cell, you will answer directly. You will answer the question blindly, that is SUR1. Yes. Let's continue the mechanism of This potassium ATP channel blockers. The sulfonylurea binds with the SUR1 receptor on the potassium channel. It closes the potassium when the sulfonylurea. Okay, when the sulfonylurea, that means any of the drug from the sulfonylurea binds with the SUR1 receptor. Okay, binds with the SUR1 receptor which is present. This receptor is present on the surface of potassium channel. Okay, on the surface of potassium channel on the beta cell. When it is bind, when the binding is happened, okay, when the drug binds to the SUR1 receptor, it leads to the closure of potassium ATP channel. It leads to the closure of potassium ATP channel. Okay, because the SUR1, SUR2A, SUR2B, all the location is different, but all these receptors are regulating the potassium ATP channels. So here SUR1 is also, it is regulating the potassium ATP channel, that is ATP sensitive potassium channel. Okay, and the drug binds with the SUR1 receptor, the ATP sensitive potassium channel is closes. It will shut down. Okay, when it is closes, the membrane get depolarization. How the membrane get depolarization? When the potassium ATP channel is closed, the efflux of potassium ions is reduces. Efflux of potassium. If the potassium channel is open, ions will be efflux from the beta cell. Okay, ions will be efflux from the beta cell from the ATP sensitive potassium channel. So when the drug binds with the SUR1 receptor, it initiates the close of potassium ATP channel blocker. So when the drug binds with the SUR1 receptor, it blocks the ATP sensitive potassium channel, so that it reduces the efflux of potassium ions. Reduces the efflux of potassium ions. That leads to the, it reduces efflux of potassium ions. So where are the ions will be stored? Inside the beta cell. The gate is closed. The gate is closed when the drug binds with the SUR1 receptors. So the ions will be stored inside the beta cell, inside the cell. That leads to the increase of potassium ions. Intracellular potassium ions are increases. That leads to the activation of calcium channels. The calcium channels get activated. Okay, when the calcium channel get activated, the calcium channels will open and the calcium influx into the cell. Intracellular calcium levels are increases. The intracellular calcium triggers and stimulate the release of insulin from the beta cell. Okay, it stimulates release the insulin from the beta cell. The insulin will get out. Okay, the insulin getting out from the beta cell. When the calcium levels are increases in the beta cell, the insulin get out from the beta cell. Okay, insulin get out. Then it will bind with all the IRS series. Okay, IRS, that is insulin receptor. Okay, insulin receptor series 1, 2, 3, 4. These are the receptors. These are the receptors of insulin. So when the insulin is getting out from the beta cell and ఎక్కడికి వస్తుంది insulin is getting out from the beta cell into the blood లోకి వస్తుంది. So after reaching the bloodstream, the blood travels throughout the body, throughout the circulation. The blood circulates throughout the body. So through the circulation, the insulin reaches the target cells. What are the target cells? Liver, adipose tissue cell, liver cells, adipose tissue cell, and also the skeletal muscle cell. Okay, these are the major target cells. These are the major target cells. The insulin is released after reaching the insulin reaches these target cells. Okay, it binds with on the target cell there is a insulin receptors. Insulin receptor, that is IRS series. IRS 1, insulin receptor series 1, insulin receptor series 2, 3, 4. Okay, to those insulin receptor series, the insulin is bound with those receptors on the target cells. Okay, on the target cells, just now I said what are the target cells, that is skeletal muscle, adipose tissue, and also the liver cell. So in these target cells, there are insulin receptors. To the insulin receptors, the insulin bind with the insulin receptors on the target cells. When it binds with the insulin receptor, it triggers It stimulates. Okay, the receptors will get stimulated, and when it stimulates, the receptor is stimulated, results in the implantation of glutathione implantation of glutathione transporter on where? On the cell membrane of the target cell. Implantation of glutathione transporter on the cell membrane of target cells. Okay, on the cell membrane of target cell. When the glutathione transporter implanted on the cell membrane of target cell, now the glucose is easily enters from the beta cell into this target cell. The glucose itself alone doesn't has ability to enter into the target cells. Okay, when the blood glucose levels are more than the normal range, the glucose should be enters into this target cells. But the glucose is not enters. The glucose alone directly not enters into this target cells. To enters the glucose into this target cell, what is the requirement? What is the requirement then? Insulin. The insulin is required. Okay, the insulin should be required to enter the glucose from the beta cell into this target cells, and then the glucose is stored in this target cell and utilized when we require, when we doing some particular muscle activities or exercise, any movements. So for those movements, for our daily regular activities, so the stored glucose will be helpful. Okay, so this is the pathway. So this in detail I explained about this general pathway. In detail I explained in my part 1 video. Look at that. So you'll get an idea. Then come to the part 2 video. Okay. Directly if you see the part 2 video about hypoglycemic agents, directly you enter into the hypoglycemic agents, you will not understand. Next one is meglitinides. Okay. The next one is meglitinides. The meglitinides, what are the drugs of meglitinides? Repaglinide, nataglinide. Repaglinide and nataglinide are the meglitinide drugs. So this meglitinides mechanism of meglitinides. Meglitinide is also has the same mechanism of sulfonylurea. The same mechanism. Okay. The same mechanism is there for the meglitinides because both are comes under ATP-sensitive potassium channel blocker. So both the classes of drugs have the same type of mechanism. But the difference is, what is the difference? The potassium ATP channel blockers in this sulfonylurea. Okay. The sulfonylurea is the main effect of sulfonylurea drugs are, which is useful for fasting and also the postprandial effect. It has the fasting and postprandial effect. That is, it maintains the fasting glucose levels and also the postprandial glucose level. That is post-meal glucose level. But the meglitinides only maintains the postprandial glucose levels. So this is the difference. Okay. The meglitinides not maintain the fasting glucose levels. It only maintains the postprandial meals. It only maintains the postprandial glucose levels, the post-meal glucose levels. Okay. Yes. And the sulfonylurea drugs are, it has a slower action, slow and longer duration of action. Okay. And meglitinide has short and rapid action. So that the meglitinide has less risk of hypoglycemia as compared with the sulfonylurea, because sulfonylurea is slow and longer lasting. The action is long lasting due to slow acting of drugs. But meglitinides are rapid, okay, rapid and short action. So due to this reason, the meglitinide has less risk of, it has a risk of hypoglycemia, but there is less risk as compared with the sulfonylurea. Okay, due to the rapid action of it. Yes, and the adverse effects of sulfonylurea drugs, which is hypoglycemia, weight gain, nausea, skin rash, and jaundice, photosensitivity. These are the ideas of sulfonylureas. Okay, The next, the areas of meglitinides. What are the areas of meglitinides? Hypoglycemia, weight gain, the same, and headache, upper respiratory infection. Okay, upper respiratory infection here.